Welcome, dear friends. Good day, good afternoon to all of our friends of the World Day of the Critical Lung. I want to welcome you to this first session. After this session, we will make the official opening of this day. But I would like to say hello to everybody, welcome you, and thank you for being here. I'm Maria Cruz Martin-Delgado. I'm an intensivist doctor, and I'm the chief of intensive care of Universidad 12 de Octubre in Madrid. I had the honor to share the moderation with Marcela Hidefshesti. And this session, we're going to have 4 presentations. And this session is organized by iWIN, Intensivist Women Association. Marcela, go ahead. Thank you so much, Maria. It's a pleasure for being here. Welcome to this great day. It's an honor to be a moderator here with Maria in the first session. We have great speakers for today. I am Marcela Vizcaychipi, and I'm intensivist anesthesiologist. I work in the UK. Currently, I'm on shift on the ICU in Chelsea Westminster Hospital in central London, and I'm the chief in informatics and insurance of the hospital. It's a great honor to introduce the first speakers. Here we're going to be discussing what it means for society, what is equity, and what is the gender difference and the importance of those differences, and consider what is right, not only in critical patients, in other kinds of patients, but how we take care of ourselves when we coordinate and work with multidisciplinary team. Society has changed and evolved. We are more confident. And we are more confident of speaking up and accepting ourselves as we are. It is very important that society like this give us this opportunity to analyze.
Societies like these have to see the current position of gender, and when we speak of gender, it's a gender in many senses of the word. So it's a great honor to welcome our first speaker, Dr. Florencia. Dr. Florencia Boiser is a hospital physician in the intensive care unit, the chair of the transfusion committee in Boreal, and in quality of the Boissier hospital. So it's an honor to have her here today, and she's going to speak on how women are able, or not support. Support is not the correct word in Spanish. I'm trying how to empower themselves, how to encourage women, other women, not only to speak, but to help each other and encourage personal development, to be able to strengthen internal skills. So Florencia, you have the floor. Thank you. Thank you for this invitation. I cannot present everything in Spanish, so I will switch to English.
About 2 actions, mentoring and sponsoring. So as Marcela said, I'm the secretary of the FEMIR group, which is the woman group of our French National Society. And as you see, we exist since 5 years, and we have many actions. through scientific publications, courses, equity in our committees, and developing network of women intensivists. We had also some tools in our website. We have many ongoing studies, and we had already several publications in the national journals or in scientific journals about gender imbalance in intensive care. So the question is empowering women. From where are we starting, and what can we do to improve it? Because as you know, there is a persistent underrepresentation and undervaluation of women in a leading position within scientific and healthcare disciplines. And you can see in this study published in Nature that women are credited less in science than men. One of the causes could be the discrimination, stereotyping, and bias, and Alpha will talk about it later. And in France, you can see that scientific prizes in French academic research centers are always mainly attributed to men. And this is the case also in our French national medical grants. You can see during the 5 past years that in the dark blue, it's the men, and that the grants are mainly attributed to men. And it is also shown in this article showing gender differences in authorship in critical care literature. And you can see that from 10 years, there is no change about the proportion of female authors. So there is really some improvement to do about it. And all this impact the promotion of women in academic medicine. As you can see it, women, associate and full professor were half as likely as men of equal rank to be appointed to department chair. So the promotion to full professor is more difficult for women than for men. And this is described in all fields of medicine, such as emergency medicine, cardiology, infectious disease, neurology, etc., etc. And even after adjustment for publications, grants, clinical trials, eyes, etc., etc. So there is clearly some barriers to female leadership, and it is the case also in intensive care medicine. And this is a very recent study of the European Society of Intensive Care Medicine published in ICM. And you can see that among respondents, the percentage of leadership positions occupied by women is very low. In most of the cases, less than 10%. In this study, the people believed that traits such as assertiveness and ambition are viewed differently if it's exhibited by a man or a woman. It's a quality when it's a man, but sometimes it's not a quality when a woman shows such traits. And the people thought that current women's behavior, that is more than being accommodating, putting others' interests before our own interest, are something that can lead to seem to be less competitive than the men in this situation. And the respondents thought also that women have fewer opportunities to build relationships required for career advancement compared to men. So many people in this study thought that a female leadership program and a mentoring program led by the European Society could be very helpful. And that is the point of this talk. And I use this very great article of Francesca Rubulotta, who described the 2 main points, 2 actions very important to promote and to empower women. That is the mentorship and the sponsorship. The mentorship focus on guidance, support, and personal development. It's a more private and one-to-one relation, and the sponsorship is an active involvement in a public as a public support to create opportunities, career opportunities. And we will start with the mentoring. The mentoring will help mentees to benefit for the insights and experience of the mentor. It will help to develop skills and personal connections. And as you see, the European Society of Intensive Care Medicine propose an approach of critical care mentoring, not only for women, but for everybody, young physician in intensive care. And it's very important to develop this mentoring. And we published with the FEMIR group 10 actions to achieve gender equity among intensivists, and clearly promoting the mentorship is one of them. And we, in our French National Society, we worked to increase the pool of women in senior academic position to serve as mentor for juniors and others. But we must be careful, as it is stated in this article, that it is difficult. Mentoring is difficult, and it is difficult because we are still in an inequitable environment. And it may be also somewhere where we can see gender inequities such as sexual harassment. So we must be careful, and that's why it's very important to have women as mentors. And we developed this in our society, for example, by promoting role models and showing that women and nurses can also have PhD. And it's important also to have reassurance and to fight against imposter syndrome. And the fact to have women mentor will help to fight against this imposter syndrome. You can see in this study that among anesthesiologists, the female are more likely to have this type of syndrome. And workshop to empower women, developing soft skills and fight against unconscious bias is also important. The second thing is to develop sponsoring. You can see in this research letter that women reported that they were less invited to write an editorial or less invited as an invited professor at another institution than men. So clearly we have to do things about it. And once again, for example, in our French society, it is one of our goals and actions to implement a concrete sponsorship. And this is through a quota policy. We decided a quota policy to have an equal representation of women in the executive board of our national society, but also in our committees and also among speakers of our national congress. And this is important, as showed once again in this article by Francesca Rubulotta, that sponsorship can help to have advancement opportunities, to break down of barriers, and to help to public recognition. So it's very important also. And it's important to develop concrete actions to do it through the peer review journals, to use quotas in editorial boards, for example, through our scientific societies and through our congress. For example, you can see that in this study of women and editorship in infectious disease journals, the fact to have more women editors will help to have more women as first and last authors. And it's important because the gender diverse teams can produce more novel and higher impact scientific ideas, as shown in these papers, where mixed gender teams have more proportion of novel papers and bigger impact factors journals. The actions that we took in our society led to an improvement of the proportion of women in our committees of our national society, but also in the chairs of the committees and the executive committee. And it also led to the improvement of the women as a speaker in our national congress. So it's important to have this action. And we choose to have quotas. Quotas we can discuss about quotas. It's probably not a long-time solution, but it's just a short-coming goal, waiting for a change in mentalities in society and in unconscious bias. For example, you can see the picture on our national website for the Congress 2 years ago. It was a picture of a woman, and this is to fight about unconscious bias that the speaker is always a man, for example. So to conclude, mentorship and sponsorship are two very important actions to take together, because mentorship is the essential foundation. It can help to the growth of the individuals, but sponsorship is a catalyst for the career enhancement. And as nicely described by Francesca in this article, we have to do both. But it is also among other many actions, such as many actions that we describe for our French society. You can see, once again, transparency and public reporting of gender ratio in editorial boards, workshop dedicated to unconscious bias, workshop dedicated to improve women assertiveness, show role models, create educational programs for intensivists, and develop research around gender inequity. Thank you very much for your attention.
Muchísimas gracias, Florence, por la presentación y por ilustrarnos y mostrarnos cómo la mentorización y la sponsorización pueden mejorar la brecha de género en nuestra profesión. Ahora tengo el placer de presentarles a la siguiente ponente, es la doctora Olfa Hamzaoui. Ella es profesora de medicina intensiva en el Hospital Robert Debré en Reims, Francia, y es especialista en medicina intensiva con certificación específica en ecocardiografía, en hemodinámica, en ventilación mecánica. Y sus áreas de interés es el área cardiovascular, el uso de vasopresores y también la brecha de género, y forma parte también de la Fundación iWIN. Actualmente es la presidenta, la representante del Congreso Nacional de la Sociedad Francesa de Medicina Intensiva, del Comité Científico, y la representante en la Sociedad Europea de Intensivos por la Sociedad Francesa. Olfa, adelante. Ella nos va a hablar de las consideraciones o considerando nuestro bias de género.
Thank you, Maria. Thank you, Maria Cruz, for the nice introduction. I would just sorry for the non-updated biography, but I'm no more the chair. I'm the deputy of the Congress of the French Society of Intensive Care. But I think it's not a big problem, a big issue. So I'll be talking I hope for 15 minutes about the unconscious bias. And first of all, I would probably declare my conflicts and of interest, and my bias, my own bias, is that I'm one of the founders of the FEMIR group that Florence just also presented to us, and also a member of the iWIN group, which is the International Women in Intensive and Critical Care Network. So what is it? What is the bias, the unconscious bias? Actually, we have two kinds of biases. We have what we call the explicit bias, which is very easy to detect because it is overtly racist. The people are overtly racist, sexist, homophobic attitudes. And so there are some discriminatory actions that we can probably discriminate and detect this explicit bias. However, the implicit bias is a little bit more difficult to detect, as they are the group of attitudes and beliefs about race, ethnicity, age, ability, gender, or other characteristics of that operate outside our conscious awareness. And it can be measured only indirectly. Some examples, and I try to give you some probably concrete examples that are related to our practice and to our daily practice. And I would begin by this example, like during the pain management, studies have shown that the minority patients, particularly Black and Hispanic individuals, are less likely to receive adequate pain management compared to their white counterparts. This bias may stem from erroneous beliefs about biological differences in pain tolerance, and these are studies coming from the US. There are also some diagnostic delays. Women, especially women of color, often experience delays in diagnosis for conditions such as heart disease. Symptoms presented by women may be interpreted differently, leading to a misdiagnosis or a delayed treatment, and as they are interpreted as emotional symptoms in order of real heart disease symptoms. The weight bias. The overweight and obese patients often face stigma and bias from healthcare providers, which can result in a focus on weight loss rather than addressing other health concerns. This also can lead to inadequate treatment for underlying conditions. Aging also. Older adults may experience age-related bias, where their symptoms are attributed to aging rather than investigating underlying conditions, and this can lead to undertreatment or mismanagement of health issues. And of course, these examples that are related to our daily practice, but we can have more and more examples about mentorship, sponsorship, hiring and promotion, grant funding, and of course the publication bias and the committee representation. In all these issues can suffer from unconscious bias. Now, how can we detect our bias and our unconscious bias? As I told you, the implicit bias is very difficult to detect. There are some tests that we can use, and the most popular one is probably the implicit association test, which is a test that you can, of course, get online, and you can test by yourself your own bias about different topics. And for example, I give you some example online, and this is how you can have the first page of this test, and they give you some items, and you choose one key of your keyboard, the right hand and the left, related to the right hand and to the left hand, and you need to touch, for example, by the right hand, when you see one photo or one word, and to associate it to what will be asked to. And I will give you something which is really very concrete online. And the left hand will be associated also to a photo or to a group, a family of words, and it is going more and more really rapid, and you need to try very quickly to respond to these, and you will see how can you associate very quickly the group, the family of words together, and this will try to calculate your own implicit bias. This is how it is presented, and I will give you just an example of when you are, when you are getting online the demonstration of the implicit bias. You choose one of the biases, for example, the race one, black and white bias, and you will have black or white people, and you need to of course choose the black face and the white face, and then after bad words and good words, and you need to organize them in bad words and good words, and then after you need to associate the black to the good and the white to the bad, and then you change the white to the bad and the black to the bad, and then after, with a really very quick procedure, and you will get how fast you will get your response of these association, and you can calculate, just to bring it back to the last, because it is the most important. to the last part, and they will measure the response. And here, for example, this is a test which has been done online, and there was a strong automatic preference for white people compared to black people, moderate automatic preference for white people compared to black, and but there was a slight automatic preference for white people compared to. It depends of the web responders of each score, and then the combination of the good words with the black faces and the white faces compared to the good words, and how fast you are responding to this. And it is really a very easy and interesting way to do. So does it really exist? This is the third question that we may ask. Yes, it exists, and this is one review that was published in 2017, and the authors, they tried to determine the implicit bias by measuring the implicit association test by using this test, and try to see among the study that was published if there are the biases, the type of biases, and which healthcare professionals are suffering from this. And they tried to use a lot of methods, for example, video vignettes, written questions, some simulations, some control settings. And what they found is that there was, among these studies, there was racial, ethnic issues, multiple issues among these studies, gender issues, or socioeconomic status or age, mental illness, different topics that were addressed in these studies. The studies also were worldwide, either they were in Europe or in North America or even in Asia. The professionals that were participating in these tests, in these studies, there was all the healthcare professionals, physicians, nurses, or both, either physicians or nurses, psychologists, and even medical students. And as I said, it was a really worldwide phenomenon, as the studies occurred in all the world. And the first result is that the healthcare professionals, they have implicit biases. Physicians and nurses manifest implicit bias to a similar degree. There is no difference. The following characteristics are at issue. They have the same degree of bias regarding race, ethnicity, gender, socioeconomic status, age, mental illness, brain injured patients, AIDS, or intravenous drug users. The second issue is that the implicit bias affects actually our clinical judgment and behavior. And there was actually a significant correlation between high levels of physicians' implicit bias against, for example, Black in the studies addressing race bias. There was a high level of physicians' implicit bias against Black on IAT scores and interaction that was negatively rated by Black patients. And there were 4 studies, for example, examining the correlation between IAT scores and responses to clinical vignettes that found a significant correlation between high levels of pro-white implicit bias and treatment response that favored patients specified as white. And 20 out of 25 assumption studies found that some kind of bias was evident either in the diagnosis, the treatment recommendation, the number of questions asked of the patient, and the number of tests ordered. The third also result is that the determinants of bias were different, were variable. There was socio-demographic characteristics of physicians, and nurses, like gender, the race, the type of healthcare setting, the year of experience, All these were correlated to the level of bias. And in one of the studies, which is interesting, that male staff were significantly less sympathetic and more frustrated than female staff with self-harming patients presenting in the hospital. The correlations between explicit and implicit attitudes varied also depending the type of bias and the kind of explicit questions asked. For instance, for example, implicit anti-fat bias, the weight topic, tends to correlate more with an explicit anti-fat bias than racial bias, where explicit and implicit attitudes often diverge significantly, because we are less, there is a less taboo around the race, around the weight compared to the race. So in conclusion of this study, the findings highlighted the need of healthcare professionals to address the role of implicit bias and in the disparities. And of course, addressing such issue, the implicit biases measures need to be taken in order to raise the awareness of the potential conflict between holding negative explicit attitudes towards some patient characteristics such as obesity and committing to a norm to treat all the patients, of course, equally. Okay, so what is the impact? Is there any impact? Yeah, there are some impacts, because in medicine, bias-driven discriminatory practices and policies not only negatively affect patient care and medical training environment, but also limit the diversity of the healthcare workforce, and this lead to inequitable distribution of research funding. And can hinder career advancement. How can we mitigate this? We can create some curriculum, as it was really nicely illustrated in this study. And when we have this is a study that addressed this issue, and there was a multivariable relationship between the medical school experiences and changes in students' implicit bias. When you complete, for example, the race implicit association tests as a part of a medical school. Sorry, Marcella, I need to stop. We are in 15 minutes.
1 minute.
1 minute, okay. So yeah, what is important is that to say that it is probably important to implement such a curriculum in order to improve our implicit bias, and even before getting in the wards and before becoming physicians during the medical students. So I will just go to the end of my of my slides, and just to give you I won't have the time to explain all this, but I would recommend you to read this paper, because there are some recommendation and 12 tips for teaching implicit bias recognition and management in order to improve your of course implicit bias your students, of course. And this was tested in some study that really found an interesting improvement of our implicit bias during the treatment of the patients. Okay, and oh, sorry, it's blocked because I'm finishing. Oh. That's the last slide. Just to tell you thank you, and to invite all the people to the International Women, the iWIN meeting in the 19 and 21 of June in Catania, in Sicily, which is a really a nice place to visit. Thank you so much.
Thank you so much, Olfa, and a great place to carry on these discussions. Thank you. So question will come at the end of the session. So we are going to welcome now la doctora Sara Saxena. She is a young and dynamic anesthesiologist, and she practiced in Gelora in Belgium. And recently, she became the course coordinator and professor of anesthesiology at the University of Mans in Belgium. So congratulations to Sara, Professor Saxena, shall we call her now? It's very important to recognize the titles because it's very difficult to get them. So Professor Saxena, her focus is primary perioperative neurocognitive research, and she completed her doctoral thesis. And I think that she has been at the UCSF in San Francisco University, and her background is just extraordinary. So her passion outside medicine is focusing especially in exploring preventative mechanism to reduce these neurocognitive changes following acute insults of the brain. I think that Professor Saxena will talk or take us through gender equality and the plan for 2024. In fact, we say 2025 and beyond. So welcome, Professor Saxena, to the meeting today.
And so before talking about gender equity and a plan, I want to go more globally. And I would like to point your attention to what's been done by the United Nations. And these are the Sustainable Development Goals. So these goals are 17 goals that have been set up by the United Nations. Oh, I'm sorry. Voilà. And so number 5 of these UN Sustainable Development Goals is really oriented towards gender equality. And so these are the goals that are set up for 2030 for us to obtain on a global level. But really from an anesthesiology, from an intensive care point of view, we are now talking about number 5. Now, why is it so important to have a gender equity plan, to talk about gender equity? Because as has been previously mentioned here by Florence and by Olfa, the careers of women are really different. So we think that people are going to go up in a very straight line, and especially between that period between the ages of 30 and 40. However, for women, as you can see, it is definitely with a lot more hurdles. Miscarriages, pregnancy, fertility trajectories, career changes, all of these do intertwine in, and especially during that period where a woman is between 30 and 40 years old. So this is really something that needs to be kept in mind when we look at the careers of women. And what's already been mentioned is imposter syndrome. And imposter syndrome, this is something that my group is doing a lot of research about, and especially Mia Gisselbach. So what is it really, imposter syndrome? Because before really pointing the blame towards the women, I do want to point out that that by talking about imposter syndrome, that it is not the women who are actually to be blamed for this. But imposter syndrome is the feeling of not belonging, the feeling that one's success is due to luck, due to being at the right time at the right place, rather than really relying on one's talent or one's hard work. And so what it leads to is a fear of failure, self-sabotage, undervaluing one's success, self-doubt, low self-esteem, and also not feeling good enough the entire time comparing oneself to others. And so what we did because I was reading about imposter syndrome. It really, in 2000, this was in 2018, and it really resonated with myself and a few of my colleagues. So we started looking at imposter syndrome in the anesthesia world, which is my background, as well as in what's around in the medical world. Not a lot of research has been done regarding imposter syndrome in the medical world. Now, when it came to looking at imposter syndrome in the anesthesia world, what we then did is a survey endorsed by the European Society of Anesthesiology and Intensive Care. And what we observed, and this has already been shown, but what we observed is that the people who suffered the most from frequent and intense imposter syndrome are women. So it's women, and mainly it's also junior women. So this is really something that needs to be kept in mind. Now, once we're aware of this problem, this imposter syndrome in our world, what we need to do is, well, we're aware of it, is definitely be an advocate for it. So what I'm now trying to do here is really mentioning this as much as possible, and then be an agent of change. And so what we did also, the same group, is that we wrote an editorial on gender equity in anesthesia, and we really looked at the different types of bias that are currently out there. So there is that explicit bias, so the motherhood penalty, that definitely is there, as I mentioned. The personal bias, imposter syndrome, and then there is that implicit bias, which has already been mentioned, so that social representation. And I will focus on these bias later on. So when we talk about imposter syndrome, I mentioned that it was a personal bias, but is it really a personal problem? Because a lot of times imposter syndrome is used to point out or to put the blame on the women themselves. However, it is frequently used to rationalize the persistence of gender bias. So women are doing a lot of non-promotable work. Women are working in structures where there is not a lot of support for them. And so what this does by blaming women for imposter syndrome is it's actually rationalizing cultural and institutional norms, and definitely perpetuating an authoritative leadership style. Now, you can be what you can see, and that nowadays we're talking a lot more about AI and how to adapt that in medicine. And so what our group did is we used two very common AI tools, ChatGPT and Midjourney, and we asked them to show us the face of an anesthesiologist and different types of anesthesiologists. And so what we observed is that pediatric and obstetric anesthesiologists, as you can see here, were depicted as women. And however, cardiac anesthesiologists, regional anesthesiologists were depicted as young males. But interestingly or notably, the head of anesthesia department in both of these AI tools were 100% white men, and also older men. So meaning that this was generated 100 times, and for these 100 times each, we never saw the face of a woman. We did the same thing for intensivists. And this is an article that's recently been published in Critical Care. And what we also observed is looking at ChatGPT, well, that nearly 100% of the head of department of intensive care was depicted as male, and nearly 70% was depicted as male by Midjourney. So these are really, so AI, and especially generative AI, and especially text-to-image tools, are perpetuating bias out there. So before we really incorporate AI into our daily practice, we really need to be aware of the data sets that it's using to train these tools. Now, when we look at the systemic solutions, what can we do? As I mentioned, the careers of women are definitely different. The challenges are different, especially between the ages of 30 and 40. So what we need to promote is a personalized career development. It's okay for women to have a gap of a few months in their career for over a decade. it's okay, and they should not be punished for this. We should create an open dialogue. We should promote practices that uplift women, and ideally, we should create a new medical culture that will uplift the next generation of all physicians. And so when we talk about imposter syndrome, there are actually two ways that we can look at it. We can look at it from one point of view, saying that, okay, there is that internal disbelief that your success is due to luck. But then on the other side is, that success is there. And what you can kind of flip that around by saying that when multiple people believe in you, it's probably time to start believing them instead of your own negative voice. And this is said by Adam Grant. So what we can do to really uplift ourselves is combat microaggressions, acknowledge our own feelings, build connections, and as has been mentioned before, find a mentor and a sponsor early on. Talk to colleagues and friends about these feelings, because once you talk about them, you notice that everyone has these. You need to decide to be confident and assertive, even though that's not always appreciated. But you also need to remind yourself that you're good at what you do. And when it comes to mentors, this is research. I'm showing you data from research that our group did regarding mentorship. And this is, once again, a research that was endorsed by the European Society of Anesthesiology and Intensive Care. And what we found is that women often have difficulties in finding mentors. So mentors and mentees choose each other based on personal compatibility. But what a lot of female mentees have said is that they think that a lot of mentors don't have interest in mentoring them. So this is really something for the next generation that we do need to keep in mind, and where perhaps we, as the established or older generation, we need to proactively perhaps show more interest in mentoring young females. I would like to thank everyone in my research group, and especially Joanna Berger-Estelita, Bashak Saidameko, Mia Gisselbach, and Susanna Vakas, as well as Onmara Bertu Chang. So we're quite global. And yeah, this is everything that is endorsed into a gender equity plan, which we will probably publish in 2025. Thank you.
Excellent presentation. Now our last speaker, and she needs no further presentation, Francesca Rubulotta. She's an anesthesiologist, intensivist, and she has been part in
she
different
has been
countries.
part of research in the UK and intensive care medicine in Catania, Italy, and is the founder of the iWIN Foundation, not only the founder, but also the promoter and the person that promotes this initiative to reduce the gender gap in every environment, especially in intensive care medicine. And she will talk about how women are a reservoir of resources that is unused. Francesca, the floor is yours.
It's now a tradition for iWIN to open this conference, and it's a great pleasure to see all of you. It's really empowering to sit at this table. So the title of the presentation is Women an Unused Reservoir of Resources. And the question I want to answer with this presentation is, are women an unused reservoir of resources? So I want to do a quick step back just to also touch upon what has been said during this hour of talk. And I'm very grateful to Luciana and now to Professor Saxena for having introduced to the concept of the foundation of the United Nations Sustainable Development Goals. These are based on the fact that no person should be left behind. And also the goal of this sustainable development project suggests that well-being is a feeling of satisfaction with life that is characterized by health, of course, but also by happiness and prosperity. And this is an important point because this is a lot related to what I will be presenting today. We already touched upon the fact that these sustainable development goals are focusing on improving gender equity, in improving health, and also in reducing inequalities. And these are three main points that I'm sure will change the scenario for future generations. Because we are here for future generations, aren't we? But what is the problem then? We mentioned that multiple times from the first to the last presentation. We have a leaking pipe. We have a leaking pipe in medicine as well as every discipline included in STEM. And this is partially due to the fact that women are less likely to have excellent letters to be funded for their research. But this is also due to the fact that women are less encouraged or able to submit and propose themselves for leadership role of grants. So the fault is a little bit both ways, and both problems can be solved through education. I give you one example just to let you understand with numbers what I'm talking about. In the field of medicine, women are majority when entering medical school. They're still the majority when entering residency program. They drop and they become a minority, talking about research assistant roles. They further drop as associate professor, and they are a real significant minority across all specialty of medicine in the job of full professor. The thing that is also worrying is that majority of people reach the point of full professor at the age greater than 50 years, which is much after men. So why is that? Well, this is not a simple answer. This is a complex answer that needs a lot of thinking around, a lot of events like the one we are participating today. And that's why many of the people around this table created the international network, a network that will be, and it is a hub to discuss about EDI issues with the core values of innovation, diversity, equality, advocacy, and leadership. We do not want to hear any more about the problems. We want to find solutions, and solutions have been mentioned multiple times, can be found through network, can be found through sponsorship, can be found through leadership. And being role models is really important nowadays to change what people have been trained and used to see. We created a YouTube channel just to propose role models and encouraging leadership into younger and younger women. And of course, we are trying also to fundraising because these very important matters are not supported by very many streams of grants or research. Every year, we meet as a group in an international conference, and we focus on specific questions. And last year, we were lucky enough with many of the chair of this session today to focus on the lesson we learned from COVID. And we asked the question, why is that clinical trials are always run in the same countries, in same specific area of the world? And you can see our chairs and many leading people participating to this event. And I just want to give you a few highlights. And the reason why we understood we have to do a scoping review. The highlights suggest that COVID-19 has changed the landscape of clinical research forever. Many things have been really proposed and highlighted. And in particular, the power of international research collaboration has been really impressive. And we still believe what has been said in the 90s, that humanity's greatest health problems can be addressed most effectively through collaborative effort by scientists around the world. We strongly believe in the power of individual network and in the need of capacity building to support networks. It is important that people are engaged, clinicians are engaged, and researchers are engaged in achieving common goals. Professor Schultz from Amsterdam brought us his experience of the PROF network, and he told us, and we totally agree with that, we need to see the real picture, how really healthcare is provided in different parts of the world, because sharing formulas from one country across countries might be the solution, but it's challenging and sometimes even wrong. You really need to... you really need to see what the working realities are in any single space. And Professor Maria Cruz brought her experience from Spain, suggesting that social problems are affecting careers progression. And this is true for Spain and in many parts of the world. And that's why Marcela suggested that we all know that women in medicine are the largest number, but few of them are involved in research. And we wonder what is that will push them to move towards more commitment. Therefore, this was a call for qualitative research and for looking every single work environment and understand what are the challenges for every single woman or young physician entering the world of research. Madia from Pakistan suggested maybe we should do a global survey, but there are very many limitations in global survey, and the most important limitation is involvement and response rate. Therefore, we decided we need to do a scoping review of this leaking pipe, of this dramatic evidence that we had through the years, and how to do a scoping review. We wanted to see a picture of the reality. Therefore, we went back to World Bank classification. We looked at every single country, dividing them in high, upper middle, lower middle, and low income countries. And then we just present you unpublished data that we are analyzing, and data that are really puzzling. You see that, as expected, the percentage of female graduate is higher than the percentage of female practicing at the bedside. But what is shocking is the amount of missing data. And these missing data are perceived in high-income country as well as low-income country. In fact, in low-income countries, maybe there are better data because the WHO has got interested and has been involved more heavily than in high-income countries. Therefore, you can see that is a huge variety, and percentage of female involved in delivering care at the bedside throughout the world is unknown. And this for me is a problem. And it's a problem because this makes difficult training and educating the workforce. If we don't know about the composition, we cannot address the needs. So this is a big problem. And the WHO has been involved only partially. National and international society have been involved only partially. Research coordinators are fundamental for the inclusion of patients in large clinical trials. They are very different from bedside healthcare providers, and they can be trained. What is important to realize that these people are crucial for expanding clinical trials around the world. They provide flexible working hours, which is great. Actually, it's something that many women would like in their work-life balance. And they are not directly clinical practice, which would be more acceptable in some economic areas. So there's some interesting ideas here if the data can be proven. First of all, I wish to use this opportunity, and we will use more opportunities to share the need of knowing and understand the composition of the workforce, of the workforces in critical care, in anesthesia, in many frontline disciplines. We can highlight the importance of trained research coordinator in upper middle and lower middle income countries in particular. We want to realize and we want to prove that maybe women that do not work at the bedside can still be heavily involved in research, and research could be a way to stop this leaking pipe. And finally, we believe that compensation or increased spending money for research development is not the only answer. We need to realize what people need, and we need to listen to what people ask before assuming what their needs are. So up until now, I think that we have done great research. We have created great networks across countries, and we have limited this because we felt it is not possible to go beyond. I do not trust this is true. We think we have many actions. I think the scoping review will give us new information. We need international data. And I strongly believe that we need to focus on training research coordinators that I believe might be made by many, many young female colleagues in middle and low income countries. I wish to thank very much people that participated to the 1.5 day debate in iWIN last year. And I wish very much to thank the people involved in the scoping review, which is a really hard effort. I wish to invite you on the 17th of December, if you like this discussion, to our Christmas webinar, where we will be asking Santa to please try to achieve gender equity. And finally, I look forward to guest all of you together with most of the people at this table, the 21st of June in Catania. And if you wish to register to have more information, please use this website. Thank you so much for your attention.